Thank you very much, and thank you very much for the kind invitation to attend this wonderful meeting. I would like to move forward because we've got a bit to cover. I don't have any great pictures of Elvis though, so let's see if I can get, oh, there we go. So you just whizzed past some pictures, but essentially these are what we do every day. We come in and care for little tiny babies alongside our nursing staff, alongside families, and hopefully so that our babies can go home with their families and do well over the coming years in development. But we recognise that we have challenges. This is data from the VIX cohort in Victoria, Australia, courtesy of Peter Anderson and Lex Doyle. And the point that I'm trying to make here are these are two very large regional cohorts from the early 90s and the later 90s. And if you look at the incidence of mild or severe impairment in childhood across these two cohorts that are separated by over 5 years, you can see that essentially there's been no change. And actually the gestational age in these two cohorts is exactly the same as is the birth weight, so it's not because there's more smaller babies. We just have not been able to make improvements in the cognitive challenges that our infants face. So why is this? Why do our premature infants still face these types of cognitive challenges in particular? And I had thought when I began my career in neonatology and neurology that if we could get rid of brain injury, if we could get rid of IVH and PVL, all of our babies would be fine. So what have we learnt about the role of brain injury in mediating these adverse outcomes? So we took this to look at the three major forms of cerebral injury in our premature population, and those are periventricular leukomalacia, or white matter injury, intraventricular hemorrhage, and cerebellar hemorrhage, which we increasingly recognize now with imaging. And there you can see here are the grades that we graded on MR. The IVH is the same as you're always used to. Cerebellar hemorrhages were either small, unilateral, bilateral, or large unilateral, large bilateral. And for PVL, there are these little tiny focal lesions here that you can see with the arrows, or more significant spots and dots, if you like, or linear scarring, which is pretty severe, or cystic white matter changes. So if these abnormalities were the major thing driving poor outcomes, let's see what we found when we looked at 340 preterm infants at term equivalent at the time they went home from the hospital. And then we followed them up 2 years later with the Bailey 2 and looked at the relationship between the presence of injury and their outcomes. And what did we find? Well, first of all, we found 220 of them had no form of any injury. And the first clue came there. So look at the MDI, or the cognitive score on these babies who had no injury. It's 86, right? It should be at least 100. So 13% of the infants had a score that was less than 70. So they were significantly developmentally impaired. 5% of them had cerebral palsy, no injury. So clearly there was something else going on. But what happens when you put the injury in? Well, you can see that for the infants that have significant brain injury, that would be sort of grade 3 and 4 scarring everywhere, or cysts, or high-grade IVH, then there is deviation downward from those without injury in terms of their developmental scores and their risk for significant disability. But overall, that accounted for about 10% of our total population. So 90% of our babies who deviated downward in terms of 1 to 1.5 standard deviations from a typical term-born infant did not have brain injury accounting for their performance. So what was going on? If it's not brain injury, what is happening in the brains of our premature babies that's accounting for some of these developmental issues that they face? We know that this period in the neonatal intensive care unit is a period of rapid and extensive change in the brain. You start with this nice smooth cortex, and look what happens in your hands. This really complicated folding goes on, and you get this beautiful brain. We can map this, and this is one infant who was imaged 4 times during the neonatal intensive care unit. time, and we can map the changes in the grey matter on the outside of the brain, or the white matter, the pale blue, or the deep grey, the yellow, or the cerebellum. And we can do brain growth curves, if you like, to see what's happening. And when we did that in about 25 babies, this is what we have, the brain's growth curve. And you can see here, this is the total brain tissue on the y-axis and the postmenstrual age on the x. And there's only two things I really want to point out to you on this curve, these curves. One is, if you kind of start small here, like Mr. or Mrs. Green, then you're going to kind of stay at the lower limit. So what happens before we get the baby also matters. But look here at the shape of the curves. From around 26 to around 34, 35, there's kind of one slope. And then there's almost a pivot point here, where there's a second slope that is much steeper. And what is happening during here is that the brain is accelerating in terms of its growth. It's almost undergoing a brain spurt from 34, 35 weeks to term. What's happening in your neonatal intensive care units at this time? I can tell you in ours, the so-called feeders and growers by then are kind of parked in the corner. We're trying to get them out the door as fast as we can. And yet the brain is in this very sensitive, vulnerable period wanting to undergo massive expansion. We can also map the surface of the brain. This is so-called cartography, just like when you map the surface of a country and look at the hills and the valleys and the rivers. And you can see the dramatic changes in folding that occur in the immature to the discharge, if you like, term equivalent brain. Look how sophisticated a term control brain is to the adult brain. All of the major folds that are going to happen in life are present at the time you are a term control. And so we need to get our term equivalent brains up to our term control brains so that we can put this basis for the rest of adulthood in place. Do we do that? Well, we've recognised for over a decade that there's a problem in our premature babies' brains in terms of growth, and now we need to understand why. So here are two babies that were both born at 27 weeks gestation. They came to the scanner on the same day. Their parents were excited because there'd been no abnormality identified on ultrasound, and yet clearly these two brains don't look alike. There's a lot of volume loss here, a sort of a diffuse encephalopathy, as it's referred to now by Dr. Volpe. So where and how is this happening? We can do this by mapping the volumes of the brain and look at where exactly these deviations occur. And we can see in particular the inferior frontal, temporal, and a little of the parietal area. But at term, we're pretty limited as to our techniques to map volume reductions, whereas in our older brains, we can use more sophisticated techniques. And these were premature babies who are now 7 years old. And where do they differ from term-born babies? They differ dramatically along the temporal lobe, a little into the parietal, and in the dorsal prefrontal. These are the regions we see dramatic reductions in brain volumes. Does that matter? Well, again, with Peter Anderson and Lex Doyle, we have mapped the relationship between these reductions in brain volume to certain types of performances, and found when you lose volume in these areas, which we see you've lost by the time you leave the neonatal intensive care unit, those reductions in volumes relate specifically to functions in childhood, such as losses along this temporal lobe area relate to impairments in language and attention, two very common areas where our preterm infants suffer challenges. So can we look at it another way and say, well, let's look at those maps of the brain and see if they tell us where the brain is different. So we have a healthy term control baby here looking out the window at a couple of babies going home from the neonatal intensive care unit at term equivalent. And what do you see? Well, I sometimes joke that this used to be like Sesame Street to me. Which one of these is like not like the other? And I think you can see when you look at them, when you look at each of these brains, like, well, you know, this one, he kind of like doesn't look right down here, right? And this one doesn't look too bad, and this one's really smooth over a lot of the areas. But it's actually very difficult technically to try and work out how to put all the brains together and be able to compare these premature born brains to a term born brain. So what we have to do is squish all the brains together from our preterm babies and compare them to healthy term-born babies by these surface maps, by overlapping them. And what do we see? We see a dramatic difference in one region of the brain, and that's the temporal lobe. So we see an impairment in the development of the folding, with it being much shallower in the premature babies than it is in the term babies. Now maybe you might say, well, sure, but just give them a chance. You know, temporal lobe's kind of a sophisticated area of the brain. They just need a little more time to catch up. So we looked at our 7-year-olds again from Australia, who now 7 years after their preterm birth, and we compared them to term controls, and we found the same pattern of alteration in the temporal lobe area. We've also now looked at a cohort of 13-year-olds from New Zealand, same pattern of alteration. So the alteration in this area of the temporal lobe is in place by the time you leave the neonatal intensive care unit, and it's present and persists right through childhood, both in terms of differences in the surface folding and differences in the brain volumes, and it matters in terms of relationship to later outcomes. So you can see it here on the surface folding and see it here in the volume. So if we know now that this temporal lobe is so vulnerable, why is it so vulnerable? So me, being the physician I am, said, well, it'll be their duct, it'll be how long they're on the ventilator, it'll be some of the different things that happened around the time of birth, and I was wrong. So then I had a very talented medical student who came and worked with us, who now is a neonatal fellow in Seattle, and she was interested in what the babies experienced. And so she developed, along with some psychologists, a neonatal infant stressor scale, which was all of the experiences of the baby were weighted by 240 nurses. So that scale at the top probably doesn't mean a lot to you, but we sort of, to put it in context, we put the average daily number of painful procedures that a premature infant experiences. And she collected this data every 12 hours in the neonatal intensive care unit. So you can see the average baby for the first month of life has 10 noxious procedures per day. What she found was that increased stress was associated with decreases in the frontal lobe width and abnormal temporal lobe diffusion and abnormal temporal lobe neural networks. And we adjusted for everything because we kept saying, wow, it's this, they got more because they were sicker. And we threw everything at it, and it did nothing to this data. To give you an example of what the neural network thing looks like, what we do in the brain is we place a little tiny seed in one temporal lobe, and we say whose blood flow in the rest of the brain is working in the same frequency, because the brain is actually an incredibly sophisticated orchestra where parts that do the same job but aren't directly connected to each other have a very low frequency of the same type of blood flow going on. So when we do this in a healthy term infant, we put our little spot in here and we say, who else is singing in tune with me? The other temporal lobe pops up and says, I am. If we do it in the low stress preterms, they're trying. I mean, they're quieter voices, but they're there. We do it in the high stress babies, no one in the other temporal lobe is functioning with the same type of frequency. There's been a disconnect, an alteration in development. This has also been looked at by other groups, in particular in relationship to neonatal pain. And this has been shown to predict cortical thickness at age 7 and also to have other alterations also within the temporal lobe region. So you can see here a relationship between increased neonatal pain being associated with a thinner cerebral cortex. So if our infants are in pain, if that may be the thing that's causing the stress, then shouldn't we be more aggressive about treating pain? Wouldn't that help? So this is work that was done by Chris McPherson, a very talented neonatal pharmacist, looking at fentanyl exposure, which was commonly used in St. Louis when I was there during that era, where 73% of our preterm infants in the study received fentanyl, and about a quarter of them received more than 100 micrograms per kilo total dose, mainly by infusion. What he found was that the preterm population was 6 times more likely to develop cerebellar hemorrhage after correction for perinatal confounders, and that the high fentanyl exposure group displayed greater impairment in head growth from birth with a dose response. There was no relationship of change in body weight during NICU admission and fentanyl dose. And indeed, on our imaging, we found strong correlations, as have others now, for higher doses of morphine in reduction in cerebellar volume and cerebellar width. We then went on to look at a different medication with morphine, and this was a cohort that had 227 babies in it, much less use over all of opioids. There was no other opioids used, and the infants only around 25% of them received any opioid, and the median dose was really just like 2 boluses. In these infants, we found at term, at the time of discharge, there was a reduction in some brain volumes bilaterally, but by 7 years we found no difference in brain surface, white matter, grey matter volume, and no difference in performance at either 2 years or 7 years. So we've moved away from wanting to use drugs and had the privilege of having a PhD student, Joan Smith, one of our neonatal nurses, look at a technique called the M technique, which was developed for palliative care to reduce anxiety as well as discomfort. And she randomized a small number of infants who were born less than 30 weeks to receive 7 minutes of the stroking technique 6 times per week for 5 weeks. And she found an increased growth velocity and signs on behavioral and physiology that the infants relaxed after the administration of this touch therapy. So then we thought, well, gosh, if the babies are this stressed, not just in pain, maybe we could make things a little better for them and make them less stressed. So we know the neonatal intensive care unit is noisy, chaotic, we exceed the sound and light recommendations, and that sound abatement is really important for developmental care and family-centred care. And we had gone through, like many, a rapid change in our NICU in that we had opened a very large series of private rooms. And so we thought, because we had the opportunity for half of our NICU to be the old, open, loud, crazy area, and the other to be these gorgeous hotel-like private rooms, that if we put our babies in these beautiful private rooms, they'd be less stressed, and the brain would be better, and all would be good. And this is what one of our private rooms looks like, this absolutely lovely, quiet, peaceful space. So we investigated the associations between NICU room type, private room compared to open ward, with our primary outcomes being medical, brain structure, and short-term, i.e. 2-year neurodevelopmental outcomes. There were 136 infants that were enrolled. They were all born less than 30 weeks, free of congenital anomaly, and they were assigned to a bed space upon admission that was quasi-random. In other words, what happened in the morning is our chief nurse would say, okay, baby 1's going here, baby 2's going there, baby 3's going there, without knowing who baby 1, 2, or 3 was. And so essentially during this time, exactly half the babies went to an open ward and half went to a private room, and they were identical in terms of everything, including insurance status, their immaturity, their severity of illness. And they stayed there until the day they were discharged in whichever place they were assigned to. The open wards are just like, I'm sure others, open wards. We had 4 open ward rooms. They had about 10 to 12 beds and about 1,100 square feet with general lighting. Parents were welcome to be present, I shouldn't say visit, to be present at any time. And here's what a single room looked like. So we studied the effect on parent presence and also on maternal mental health. And we found that in the single rooms, the parents did visit more frequently, about an hour a day, but the parents also reported more feelings of stress and anxiety, particularly in relationship to their isolation from other families, and also in terms of the fact they were worried about their baby being in a single room without a nurse being present. They were worried about leaving. So those were their reports. We did AEG and plotted Bergaloff scores. We found no difference at the time of recruitment at 30 and 34 weeks, but interestingly, at the time of term equivalent, the infants in the single patient room had lower brain maturation scores. We then followed the babies up at around 2 years, and we looked at the association between room type, cognition, language, and motor. We controlled for early severity of illness with CRIB2. We looked and controlled for cerebral injury, social risk score, and family functioning. And what did we find? Well, to our surprise, it's always good to be a scientist, what we hypothesized, we were wrong. The infants in the private room showed lower trend in terms of their cognitive development. They showed lower performance in terms of their motor outcome, and most strikingly, their largest deficit occurred in language outcome. So we took a deep breath in and said, okay, what happened here? And we went back to our imaging in our brains. Now we know that if I looked and flip-topped all of your brains, that your left and right hemispheres aren't the same. You know that if you, from your old neurology days, if you have a stroke on one side, certain things go wrong or the others. And in the temporal lobe area, this area we're very interested in, there's a deeper area in the temporal sulcus on the right that's particularly involved in behavior, facial recognition, social interaction, and some language, and 2 deeper areas on the left. Now, we hypothesized that these wouldn't be present in babies because you'd have to see faces, right, and hear voices and all those things, and we were wrong. So here is a term-born baby, healthy term-born baby. All of these hemispheric asymmetries for these functions are in place at the time you're term-born. So next time you pick up that healthy term-born baby, there's a lot that is in there, so don't underestimate them. What happened in our room environments? In the open bay, they were really trying to form these hemispheric asymmetries. In our single patient room, they couldn't, they didn't. In fact, David Van Essen, who's a neuroscientist who works his entire life in looking at environmental influences on brain development, said this was the most startling alteration in structural brain development due to environmental exposure he had ever seen. Why? So we've been putting leaner devices, these lovely things that capture the auditory environment, and this is just an example of the recordings in the open ward. Not ideal, right? The purple is noise. We know this, too much noise in our environment. But the blue is language. So if you look here at around this time, this is nursing handover, right? Chat, chat, chat. Baby Joe is listening to what the nurse is saying about baby Jane, and they are hearing all of this. So there's a lot of language that's still going on. Look in the single private room, silence. The only thing that is occurring is the electronic noise of the alarms because the nurse can't get to the pump quickly enough because she's still dealing with the baby in the other room. And believe it or not, there was a mother present for 6 hours of this recording, but she also was completely silent. This has been observed by other groups. Betty Vore has been studying this as well in terms of using the same device to look at the amount of language exposure to our preterm population and has shown that the amount of parent talk, it's not actually parent, it's actually adult talk, so it could be the nurse or the parents because Betty wasn't able to listen to the recordings, but whatever the babies are hearing is correlating with their later language outcomes after discharge. So this is a very critical phase of brain development, and it's really the old you use it or you lose it theory, that they, as fetuses, are listening. They're listening to their mothers, they're listening to their fathers, they're listening to other things, and that if you don't use it, you will lose it or you'll refashion it. Alan Jobe wrote an editorial around this study talking about the risk of sensory deprivation in the neonatal intensive care unit. And I want to emphasize that this concept of experience relates to more than just the auditory experience. As you could see, it's the stressful experience, the painful experience, the auditory experience. And in fact, when you go back, and I would encourage those who have never seen this video to go back and look at it, Harlow was a scientist in the 1950s who tried to find this sort of basis for the science of love and nurturing as being pivotal for human development. And he used this with Rhesus monkeys, where the monkeys had a wire mother that provided milk and a cloth mother that provided some form of comfort. And the little monkey would run and have some milk, but then quickly spend the entire rest of their time really cuddled up and gaining benefit from the cloth mother. So what happens in our neonatal intensive care unit? Do we have the cloth mother or the wire mother for many of our infants' experiences? One could look at this just with data from kangaroo care, and this is just one of many studies, but an important one with long-term follow-up, where infants were randomised to just 1 hour of kangaroo care each day for 14 days, showed improved outcome at the time of discharge, but most importantly, 10 years later, improved cognitive development. Half of the benefit was through improvement in parent-infant attachment. So in summary, brain injury in its severe form does impact neurodevelopmental outcomes, but it's not the key driver. We really have a lot of data now showing that the neonatal intensive care unit experience and exposure matters during this highly critical period of brain development, that stress and sensory isolation appear to adversely influence brain structure and outcome. I haven't had time to touch on it, but we're going to spend the afternoon on nutrition, which is also critically important and commonly impaired. And the period to term equivalency, I can't emphasize this enough, is really critical in brain development and worthy of much greater focus both during healthy pregnancies and obviously in our infants born early. Finally, parental mental health, empowerment and attachment are also powerful for outcomes, and we need to be potent advocates in each of our nations for our parents to be present and engaged in the nurturing of their infants. And finally, I hope I showed you that imaging has been a powerful biomarker for us. This is what we want to have. We want to be able to have mothers, fathers, and their babies all leaving our experience well. And I thank you for your attention.